everybody, Science Dispatch Podcast. Welcome back. So glad to have you with us. My name is Cameron English. I'm your host as always, joined by Dr. Chuck Dinnerstein, Director of Medicine at the American Council on Science and Health. Chuck, what's going on? How are you?
I'm feeling fine. It's a lovely day here in the neighborhood, and we're looking forward to the height of summer. The lawn is dying. The sprinklers are on. I'm receiving notices from the water people that we have to turn our water off. So all is good.
It's a brisky 111 out there. All you need is a light sweater.
Right. And as you know, it's a dry heat, and so I feel more like I'm in a tandoori oven than in a steamer.
That's right. Yeah. If you go outside, it feels like a pizza oven. It doesn't feel like, I don't know, a shower without the safety on your water heater. That's what it's like. Although I will say, before we get into what we're here to talk about, the whole dry heat thing I think is silly, because once you go outside, your back starts to sweat and it's not a dry heat anymore. It's indeed a very musty, nasty. So there you go. There you go. Basically, I'm ready for fall is what I'm trying to tell everyone.
And I would just throw in a meteorologic point of view is they love now to report the feels like temperature, because it's even higher than the regular temperature. So even though it's 92, they can report 100. So once again, a bigger number. They love reporting those bigger numbers.
Yeah.
So that's how they do it.
Yeah, they actually hire an alcoholic boomer who just sits on his roof with his natural ice, and they go, "Hey, Fred, what's the temperature feel like?" He goes, "It feels like hell. It's 117." I just made that up. There's probably no weather channel, no TV station that does that. But if they do, that'd be funny, wouldn't it? Okay.
It would.
Okay, we got another story to talk about. This one is by our own Dr. Dinnerstein. This one's called Red Meat Revelations, Cutting Through the Fat of Nutritional Epidemiology. I like what you did there, Chuck. That is very punny indeed. Let me read this introduction and then you take it away. So, you write, nutritional epidemiology is notorious for producing sensational, conflicting results that confuse us all. We're stuck with observational studies that can be twisted in countless ways to get different outcomes. Enter a new tool aiming to cut through this mess by testing all possible analytical choices and showing how flexible and unreliable these studies can be. Chuck very smoothly sticks the shiv in at the very end. Break this down for us, Dr. Dinnerstein.
It was really a great study, and I have to give the researchers credit, because their study was really talking about a new methodology to look at whether any given nutritional study has any merit. But they decided to use, as their example of the technique, the nutritional studies on red meat. So it would gather some attention, because it's a contrarian point of view showing that red meat is not necessarily bad for you at all. So I jumped on it right away because I had to find out what was going on. So there's been a lot of back and forth about the concepts of statistical significance. Dr. Stan Young, who's written a lot for the ACSH, talks oftenly about the concept of p-hacking, where people go through various studies and looking for variables until they find a p-value that's good and report it out. And this is another technique to look at these studies to get a better sense of how valid they may be overall. So a nutritional study is most often observational. The only study I know that involved a randomized control study was a study on people eating ultra-processed foods, where they locked 30 people up at the National Institute of Health for a month and gave them a specific diet. So those kind of studies are not going to get done a lot. Not a lot of people want to go to the NIH to live there for a month. So most of these studies are observational, and they have biological components, they have sociological components, and as a result, they have a plethora of variables to choose from. And which variables the researchers choose to accent and how they categorize and explain those variables are all subjective judgments that influence the outcome of the studies. So in this case, the researchers use a technique that they described as a specification curve analysis, which is a very fancy term. But basically, they look at all the variables and the various combinations of how those variables come together. And so to give an example, they asked the question of whether red meat is responsible for greater all-cause mortality. They looked across the literature and found 15 papers that categorized 24 observational studies, and they used this to explain their technique. Across the 15 papers, there were 10 trillion unique combinations of variables to put together. So that big a playground means there's a lot of room for mischief. So there's no way computationally they could even do anything with that. So they took 1,400 of those pairings and made use of the National Health and Nutrition Examination Survey, the NHANES, that's used by everybody, and looked at data from that against their variables and against the National Death Registry, looking at how many people died. So they took 10,000 participants from the study, and they took the 1,400 combination of variables, and they gave it to the computer. They didn't tell the computer how to sort the variables. The computer sorted them all in any different way it could. And it found out in the end that 36% of the studies designed by the computer using all the variables resulted in death. 64% didn't result in death. When they really reduced that to the statistically significant combinations, they found that red meat, if anything, reduced mortality. Quite a difference from what is told to us by the chicken producers. So they make the point that the technique is non-definitive, but it does provide a picture of the combinatorial landscape. And I think that there's a great validity in that. Nutritional studies, and those are the ones that we always go back and forth arguing about and fighting about what they're meaning, are full of variables. And we have to be cognizant of the fact that the researchers are using subjective judgments in determining which variables to study and which variables to highlight. And as I said in the previous podcast, oftentimes their variables are limited because of the data sets that they have available to them.
Just as an aside, I think you're talking about Kevin Hall's study from 2019.
Yes.
Where they locked people up in a hospital ward. Not locked up is the wrong word, but they
yes.
housed people in a hospital ward. Hall came out a couple years ago and said, I actually don't think ultra-processed food is that bad.
No, in fact, last year, there was a talk from the T.H. Chan School of Public Health at Harvard talking about ultra-processed food, and he was the most rational one of all the ones sitting there. He said he has to admit he actually eats ultra-processed food because sometimes he's busy and it's convenient, and he doesn't believe it's killing him.
Yeah. So in other words, instead of doing another clinical trial with public money, just talk to Chuck and I. We'll help you. We'll help you get to the bottom of it. Unsurprisingly, it's moderation and the nutrient content in your food. That's what affects your health. You're welcome. Where's my grant at? Please. In all seriousness, Chuck, I don't understand, because so much of this podcast is dedicated to unraveling these kind of studies. I don't understand what purpose this serves. I mean, NHANES probably has some usefulness, but as we talked about recently, these data sets are falling out of date because, you have the people involved who are enrolled are dying or they're dead. Demographically, they're often very different than the people who are running around today in the United States. And the data is often, it's infamously unreliable. There was a study a few years ago where some researcher came out and he said, based on this NHANES data, if people honestly ate what they reported eating, they'd be dead because they didn't eat enough to survive.
Fair
so,
enough.
so in other words, I guess what I'm getting at is, what are we doing here?
Well, I think there's some advantage to longitudinal studies. I think that they do give us some information. They just don't answer all the questions. Now, the researchers have found themselves a new shiny object to which they are going to move themselves more and more, which is the electronic health record, because we collect that every day. And so and it appears to have lots of information in it. So this may be another one of the great gold mines, especially as they find they can begin taking information from an electronic health record and matching it up with data from a genetic data set and creating floss or gold, depending on your point of view, from how they weave that material together. Now, my experience with databases goes back to working with the American College of Surgery on their safety and quality database at the hospitals. And they had a very large data dictionary for everything that had to be recorded. Moreover, they required the people that gathered the data to go take a 6-week course and prove that they could actually analyze the data in the same way. And so I thought that data registry made a great deal of sense. The electronic health record is populated by physicians like myself, Bobos. And we don't often categorize things in the same way between patients or with the same patient over time. My favorite example of that is that when you do a cardiac catheterization or a peripheral intervention and you do it percutaneously with a needle, the recognized complication from that is a hematoma, which is a collection of blood. And that's reportable to the quality data sets. And you have never lived until you sat at a meeting where the cardiologist or the surgeon is explaining to you why that particular problem was not a hematoma, even though it created something the size of a grapefruit in the guy's groin. That was just some swelling. And this is why the data in a lot of things, especially the electronic health records, are more subjective than we would like to believe, and it's going to lead to more and more problems down the line.
Well, if I'm not mistaken, a lot of the information in a health record is self-reported as well. So when you go in and they say, how many drinks do you have a week? And you go, between 3 and 7.
Right. Nobody drinks.
Right. Nobody drinks.
Okay.
Same thing with your weight. And like, there isn't necessarily anything devious about this, but like if you go into a doctor's appointment in the middle of the day after having had 2 meals and then you get weighed, that's going to skew that number. And so if you multiply that by however many millions of health records.
It's no different than, when you go in to get to the doctor's office to get weighed, nobody asks you to get naked. You get on the scale, which may or not be actually calibrated against something, but you do get on the scale, and then they take off anywhere from 2 to 4 pounds, depending on their mood, from the weight of your clothing. Now, I always wear heavy clothing when I go. I wear at least 15 pounds of heavy clothing because I don't like the numbers that the scale does. And this is no different than, I cannot tell you how many times they have taken my blood pressure with me wearing a sweatshirt. I don't know how they can hear anything, let alone get an accurate reading on my blood pressure. But these are the numbers that populate the record. And as you know, it's a number, so it must be correct. It's not like, tell me what your level of pain is on a scale from 1 to 10.
Well, and what's fascinating to me is that in a lot of these epi studies that you read, they will say, concerns have been raised over the years about the reliability of self-reported data, but we checked our results against electronic health records. And so this is sort of brought in as sort of like a fifth gospel. They're like, but, we have the electronic health record, and then it comes down from heaven on the backs of angels, right? So that's an important point in that the thing that they're checking the results against is actually not much better in many cases.
No, not at all. But we have to, from the clinician's point of view, we have to find some value to filling out this billing system that has been foisted upon us by the administration, and this seems to be where it is, and it's good in terms of it will capture the laboratory data and put it where it belongs. But I read my well. With few exceptions, the physical examination reported in the electronic health record is more of an aspiration than something that actually occurred. And this is going on for many years. I mean, I can remember reading med malpractice cases where I was doing it as a vascular surgeon, and the person had a dead leg, couldn't even move it anymore, and then the nurses are reporting pulses. So who do you want to believe? The leg or your lying eyes?
Yeah, and that's a good point too. As we wrap up here, is that as a physician, you're standing in front of the patient. So if you say, "Hey, do you use illicit drugs?" and you can see track marks in their arm, and they go, "Nope, never touched the stuff," then you go, "Huh, maybe that's not the full story, right?" And then whatever the record says, you as the physician can make adjustments and sort of determine if the patient's lying through their teeth. Whereas,
well, you could make adjustments in the past, but now that we have to be more careful about what words we use, we certainly can't say that the patient was. I mean, we can't even say that the patient was non-compliant with therapy, because that seems to be too much patient blame.
Yeah, so maybe instead of dishonest, you could say voluntarily misinformed about their own health status. I don't know.
I don't even know how you would record it.
I did a podcast interview recently about harm reduction, and apparently even using words like consequence in relation to drug use is no longer appropriate. So to say yeah. So there you go. I don't know. Whole nother topic, but I guess the moral of the story here is red meat, provided you don't put 10 sausages in a blender and guzzle them, is going to be okay. Is that what you're telling me, Dr. Dinnerstein?
Well, no, that's what they report, and I'm happy with that. But I think that what the real value was pointing out that nutritional studies and sociologic studies, studies that involve human behavior, let's put it that way, have so many variables in it that one needs to take with a grain of salt the variables that they have chosen to use to explain the phenomenon, because there are many times, in the words of Donald Rumsfeld, the unknown unknowns that are just as important as the ones that the researchers have identified for their grant.
Chuck's jokes, by the way, are hilarious. I'm just on mute, so I don't have background noise contributed. But these are quite funny, the way that you sum these things up. Well, I guess the good news is the people that spent decades publishing crappy research now have a tool to identify the crappy research. So thank you. Thank you, science. Another triumph for public health. With that, we're going to wrap it up. Thank you for joining us as always. Follow us on social media. It's at ACSH.org. On Twitter, I am at KMJ English. Send us your questions and your comments. If you have a suggestion for a topic, we'd love to hear it, because we like talking about stuff the audience wants to know about. And with that, we will see you next time.